Hi, it's me, Brodie McLeod, again with my unwatched, unrated, unsubscribed, unliked, irrelevant, and totally sparse and banal YouTube videos. So thank you for watching for 14 seconds. Please don't click pause or look at some other horse shit on YouTube instead of listening to me. Even though I've got a little bit of dinner on my jumper, I'm still a very interesting man with lots to say about the world and life in general. One thing that's really shit, right, is getting sectioned under the Mental Health Act. We changed it in 2025, and they sort of tried to bring mental capacity and mental health kind of into one thing. And they've got this fucked up law about people getting sectioned in their own homes, which is weird. Not many people know about it, and like it could affect quite a lot of people. So I've done some AI research, which I'll just read to you if you don't stop the video and find something else better to do with your brief minutes and hours of your life. So I'll hit this open button and read you this, and hopefully I'll get at least 10 views. The Great Reform, the Mental Health Act 2025, and the Paradox of Community Constraint. The 18th of December 2025 stands as a monumental date in the narrative of British social policy, representing either the dawning of a new era of psychiatric liberation or the quiet consolidation of a more perversive form of state control. On this day, the Mental Health Bill received royal assent, ushering in the most significant overhaul of psychiatric law in England and Wales since the 1983 framework was established over 4 decades ago. The Mental Health Act 2025 is a complex, multi-layered piece of legislation, seeks to modernise a system long criticised as outdated, paternalistic and prone to systemic inequalities. At its core, the Act is driven by an ambitious desire to reorient mental health treatment towards the principles of dignity, autonomy and therapeutic benefit. Yet the first provision began to take effect on the 18th of February this year. Profound tension emerged, a tension between the promise of enhanced outreach for those suffering in silence and the implementation of what some civil liberties advocates describe as draconian and totalitarian measures. The Act arrives against a backdrop of a mental health system under severe strain, with hospital beds at 100% capacity and community services struggling to manage the rising tide of urgent referrals. The legislative shift towards neighbourhood care as both a clinical necessity and a profound logistical gamble. The 2025 Act does not replace the 1983 Act. Instead, it fundamentally amends it, tightening the criteria for detention whilst simultaneously expanding the power of the state to supervise individuals long after they've left the hospital ward. This discussion-based narrative explores the dual nature of these reforms, questioning whether the expansion of patient rights is being shadowed by a new digital panopticon of community surveillance. So now we look at the philosophical reorientation from sickness service to patient autonomy. So the architecture of the 2025 Act is built upon the recommendations of Sir Simon Westley's 2018 independent review, which sought to put choice and autonomy at the heart of the law. For 40 years, the 1983 Act functioned as a sickness service, often prioritising risk management over the individual's lived experience. The new legislation attempts to correct this by enshrining 4 guiding principles on the face of the Act, which must now underpin every clinical and legal decision made in the psychiatric system. So the 4 principles of the 2025 framework. In column 1, we've got choice and autonomy, least restriction, therapeutic benefit, and the person as an individual. The intent and the mechanism of all of those. First one, patients must be actively involved in their care plans. Their preference must be the starting point for treatment. Below that, we've got any interference with liberty must be the minimum necessary to ensure safety. Detention, below that, is only lawful if there's a reasonable prospect of alleviating or preventing the worsening of the condition, and clinicians must account for the patient's identity, culture, values, and past experiences. Then you've got the social and clinical implication. It would be much better if you could see the whole thing, but you can't, so you're just going to have to suck a bag of dicks. But shift the power dynamic from clinician-led to patient-centred, theoretically reducing the trauma of compulsion. The next bit aims to move away from the locked ward default, encouraging community-based alternatives. And number 3 prevents warehousing of patients when no effective treatment is being provided, a crucial protection for those with complex needs. The last bit is directly targeting racial disparities and ensures that treatment is culturally appropriate rather than like one size fits all. And here's the first bit. So you've got choice and autonomy, least restriction, therapeutic benefit, person as an individual. I can't show you the whole thing because I just don't have that kind of power. These principles are not merely aspirational, they're statutory requirements. Section 1 of the Act mandates the Secretary of State include these principles in the Mental Health Act Code of Practice, effectively making them the moral compass for thousands of practitioners. The introduction of advanced choice documents, ACDs, represents the most practical application of this shift. These documents allow individuals to record their treatment preferences while they have capacity, ensuring that if they later fall into crisis where they lose capacity, their previous self still has a seat at the table. Clinicians are now legally required to have regard for these documents, which can specify preferred medications, interventions to avoid too, and even dietary or cultural needs. This is the enhanced outreach and action, a proactive effort, hate the word proactive, to engage with patients before they reach the point of total collapse. By empowering the patient to plan their own crisis response, the Act seeks to restore a sense of agency that was often stripped away by the blunt force of the 1983 sectioning process. However, the effectiveness of these documents hinges on a well-resourced community infrastructure to help create and store them, a concern echoed by charities like Rethink and Mental Illness. Both of them aren't very good charities, in my opinion. I've tried to reach out to them and their legal teams, and they've kind of just gone to me, which wasn't very, very nice. But I'm sure they do help a lot of people, and I would donate to them, I suppose. The serious harm threshold, raising the bar for incarcerations, one of the most profound shifts in the 2025 Act, concerns the legal grounds for detention. Under the 1983 Act, criteria for detaining a patient under Section 2, assessment, or Section 3, which is treatment, were relatively broad, often requiring only that the detention be in the interest of the patient's, quote, health or safety, or alternatively for the protection of others. So you've got to be proven that you're a danger to yourself or others to be sectioned. The 2025 Act significantly raises this threshold by introducing the serious harm test. So there's another table there, comparison of detention thresholds and timelines, which you can't read because I can't be bothered to read it to you. The tightening of these screws, this is a direct attempt to reduce the volume of detentions in England and Wales, which has reached record levels in the decade leading up to the reform. Clinicians must now provide more robust evidence of risk before they can deprive an individual of their liberty. Furthermore, the reduction in detention periods, halving the initial treatment phase from 6 months to 3, is designed to prevent institutionalisation. That's, I think, something I've suffered from. By forcing more frequent reviews, the Act mandates that the state must continually justify its interference in a person's life. However, the increased scrutiny brings its own set of challenges. The serious harm test is a high hurdle for clinicians who are already managing high-risk caseloads in critically overburdened services. There's a fear that by the time a patient meets the serious threshold, they may have already suffered irreparable psychological or social damage. The government's removal of the how soon requirement from the draft bill, meaning harm does not need to be imminent, was a concession to those who worried that waiting for a disaster would undermine the proactive goals of reform. It's kind of management by crisis, wait until you completely lose your shit and then you might get sectioned and put into a hospital or might not. The supervised discharge dilemma is liberty versus the community ward. If the tightening of detention criteria represents the enhanced outreach of the Act, and the introduction of supervised discharge is where the narrative shifts towards the more controversial draconian elements. The new power introduced via Section 35 of the 2025 Act creates a subset of conditional discharge that allows the deprivation of liberty to follow a patient from the hospital into the community. The legislative impetus for this was the Supreme Court 2018 ruling in Secretary of State for Justice versus in the court found that the 1983 Act did not give Mental Health Tribunal or the Secretary of State the power to impose conditions on a discharge patient that amounted to a deprivation of liberty, even if the patient consented. So this created a lacuna where many restricted patients who were clinically ready for community life but still required 24/7 supervision to manage their risks remained trapped in high security hospitals. They were effectively detained by omission because the law couldn't authorise a specific level of community control they needed. Sort of the position that I'm in. I've been locked up now in a hospital for it'll be 2 years in July. I mean, no, we're only in April, but it's getting there. Section 35 of the 25 Act reverses by explicitly authorising conditional discharge with a deprivation of liberty, often abbreviated as CD-DEP. Under this regime, the tribunal can authorise a patient to live in a community placement subject to conditions such as continuous supervision and control by staff, a requirement to be escorted at all times when leaving the accommodation, restrictions on who they can meet and where they can go, exclusion zones. So the ethics of capacity blind supervision. The most striking feature of supervised discharge is that it's capacity blind. The tribunal can impose these conditions regardless of whether the patient has a capacity to make that specific decision. While this is intended to prevent people from being stuck in hospital, it creates a profound logical conundrum. So a deprivation of liberty by legal definition under Article 5 of the European Convention on Human Rights is something to which a person does not consent. Yet the tribunal's own guidance suggests that if a patient actively objects to the conditions, they should not be imposed because the community staff have no legal power to physically restrain a patient who chooses to walk out of their house and do whatever they want to do. So this creates what critics call a paper tiger system of control. If a patient is deemed too high risk to be unescorted, yet the staff have no power to stop them from leaving, the placement relies entirely on relational security, the patient's willingness to comply under the threat of being recalled to the hospital. For some, this is a masterpiece of least restrictive outreach. For others, they see it as a totalitarian move that turns the community into an extension of the asylum, where the watchtower is invisible, but the walls of the escort requirement are very real. Neurodiversity and Section 3 exclusion. Is it liberation or abandonment? Central pillar of the 2025 Act's humanitarian mission is the disgraceful treatment of autistic people and those with learning disabilities in the previous system. Under the 1983 Act, thousands of neurodivergent individuals were detained for treatment under Section 3, often for years, simply because their condition was classified as a mental disorder. These individuals frequently subjected to environments that exacerbated their distress, leading to the overuse of physical restraint, seclusion, and over-medication. I'm on like 4 medications at the moment. I don't like any of them, really. The 2025 Act fundamentally changes this by removing autism and learning disability from the definitions of mental disorder that can justify long-term detention for treatment under Section 3. Here's another boring table. Charities like the Challenging Behaviour Foundation have hailed this as an important first step, but the implementation is fraught with anxiety. The government has stated it will not enact this specific part of the law until it's satisfied that strong community support's in place. The delay highlights the draconian reality of the status quo. Without proper housing, sensory-friendly environments and specialist community teams, the state cannot afford to liberate these individuals. Critics warn of unintended consequences, such as the Mental Capacity Act 2005 being used as a backdoor to deprive people of their liberty in hospitals without the specific safeguards of the Mental Health Act. The digital panopticon, surveillance as a tool of outreach. The Act pushes treatment closer to home. It inevitably intersects with the digital panopticon of 2026. In an era where everything is monitored and logged, the concept of supervised discharge becomes inseparable from the technologies of surveillance. While the Act itself does not mandate GPS tagging, the broader policy shift in the justice and health sectors suggests that electronic monitoring EM is the invisible hand that makes community discharge possible. The panopticon effect is a psychological mechanism where individuals self-censor and modify their behaviour because they know they might be being watched. For a psychiatric patient on supervised discharge, this can be cognitively exhausting. The pressure to perform an accessible version of oneself to avoid being recalled to hospital ward can lead to identity fragmentation and, of course, increased anxiety. Big Brother Watch and other privacy groups have argued that these measures are narrow and draconian, risking a world where punishing thought or thought crime becomes a reality. If a patient's GPS data shows them lingering near a prohibited area, is that a clinical early intervention or a preemptive strike by the state? 2025 Act does not answer this question. It merely provides the legal framework for these two possibilities to coexist. Institutional inertia. The NHS and Department of Health and Social Care merger, the upscale mental health treatment promised by the Act, is also threatened by a massive top-down restructuring of the health service. In March 2025, the government announced the abolition of NHS England, bringing operational control back into the Department of Health and Social Care for the first time in over a decade. This reintegration is aimed at creating a neighbourhood health service that focuses on prevention rather than late-stage diagnosis. However, the re-imaging of the NHS comes with draconian financial targets. Integrated care boards have been tasked with cutting their running costs by 50% in 2025-26. For some integrated care boards, this means cutting budgets by more than 2/3. At a time when the 2025 Act requires more advocates, more tribunals, more specialist community staff to manage supervised discharge, the system's been asked to live within its means by stripping away its administrative leadership and its capacity. The 2025 Act places a statutory duty on health bodies to help with advanced choice documents and statutory care plans. Without the staff to facilitate these conversations, these rights become empty promises. The CQC has already voiced concern that gridlocked services are preventing the flow of patients out of hospitals, with nearly 60% of patients ready for discharge experiencing delays in March 2025. In this context, supervised discharge might be seen as a way to clear beds by imposing supervision on families and under-resourced community teams, effectively privatising the control of the psychiatric ward. Human rights landscape, Article 5 versus Article 8. So 2025 is a battlefield for competing human rights claims under the Human Rights Act 1988. Every deprivation of liberty engages Article 5. So that covers the right to liberty and security, while every compulsory medical treatment engages Article 8, which is the right to private and family life. One of the most praised outreach elements of the Act is the extension of the Human Rights Act's duties to independent mental health care providers. Previously to that, there was a legal loophole that meant that private providers, often funded by the NHS to provide community aftercare, were not always considered to be carrying out a public function, leaving patients like Paul, who died. Excuse me, I've lost my place. I thought they were about to do my obs on the door. I had to pause the video. One of the most praised outreach elements of the Act. Oh, they are. There we go. Yeah, they were just doing my obs. I'm not allowed to record anyone's voice other than my own, so I have to be very careful. One of the most praised outreach elements of the Act is extension of the Human Rights Act's duties to independent mental health care providers. Previously, a legal loophole meant that private providers... Well, this is going to be fucking fragmented. Yeah, that was just somebody bringing my meds to my door. Independent mental health care providers. Previously, a legal loophole meant that private providers, often funded by the NHS to provide community aftercare, were not always considered to be carrying out a public function, leaving patients like Paul who died in a private care home with fewer legal protections. The 2025 Act closes this gap, ensuring that whether a person is in a state hospital or a private community ward, the human rights are the responsibility of the provider. However, the draconian critique persists regarding the nominated person for those under 16. While the Act replaces the nearest relative hierarchy with the person of the patient's choice for adults, the rules for children are more complex. Parliamentary debates, the ping-pong stages, revealed concerns that the Act didn't go far enough in protecting the autonomy of young people, particularly those in gender distress or those who lack parental support. The refusal of the Speaker to hold a vote on certain amendments regarding culturally appropriate advocacy and the test for capacity for under 16s left a lot of campaigners feeling that the Act's reach was curtailed by political caution. In conclusion, a narrative of unresolved tension. So the Mental Health Act 2025 is a profound experiment in the governance of the mind. It offers a vision of enhanced outreach that's genuinely moving, replacing bloodline hierarchies with nominated persons and enshrining the wishes of the well self in advanced choice documents and enduring the traumatic warehousing of the neurodivergent. These are the marks of a society striving to treat its most vulnerable members with dignity and respect. Yet the Act also constructs a infrastructure of totalitarian potential by legalising supervised discharge in a capacity-blind manner and integrating the digital tether of electronic monitoring into the community. It risks creating a world where freedom is conditional and surveillance is ambient. The serious harm threshold, while designed to protect liberty, may inadvertently create a system that only intervenes when a crisis is catastrophic, leaving the early intervention promise of the 10-year health plan unfulfilled. Again, like I said, management by crisis. They're called the crisis team. If you have a mental breakdown, that's who your 111 or 999 will refer you to. And it will quite often be, it's like you don't stop eating cheeseburgers until you suddenly have a heart attack, Only time will tell which of these narratives will define the 2025 Act's legacy. As these new powers are woven into the social fabric of British society, we must question whether we're truly expanding the scope of upscale treatment or merely eroding the very dignity and freedom the Act was supposed to protect. The government's long-term implementation plan means that the full impact of these changes won't be felt for a decade, but the conversation starts now. Is the community ward a compassionate alternative to the hospital, or is it a draconian expansion of the state's gaze into our most private spaces? The answer lies not just in the letter of the law, but in the resources we're willing to provide and the values we're willing to defend in the pursuit of modern mental health service. Thank you very much for watching my shit YouTube video. I hope you have a great day and you have good mental health. Thanks. Bye.